Hello, my name is Amy Labar and I will be presenting a case study on Mr. Rivera. So to begin, how do we talk amongst each other in the healthcare system? We use something called an S-bar, whether we're calling report to another floor, the ER to med-surg to ICU, discharging to another facility, calling a doctor's office. We use an S-bar. This is an acronym to help facilitate prompt and appropriate communication. It's a logical way that we should give report to ensure all information is given and received and repeated back, especially when orders are involved, to the giver to make sure we don't make mistakes. It provides a predictable structure between team members and we all understand what's coming next so we don't miss anything. S stands for situation, B for background, A for assessment, and R for recommendation. First, the situation. A concise synopsis of what the problem is, what's going on. In this instance, Mr. Rivera is a 63-year-old male. He's obese, has type 2 diabetic, and it's uncontrolled. He was admitted to the rehab center from a local hospital after an amputation of his foot at the ankle that he had a non-healing wound to that turned gangrene. After surgery, he did okay, but a couple days before discharge, an infection appeared. They put a treatment of antibiotics in 2 days prior to the discharge to the rehab facility. Now, he continues to have symptoms and not doing well in therapy due to pain. B for background. What's the brief information related to the above situation? Well, after surgery, he had a fever, red worm area to the incision site. Like we said, he was discharged to the rehab facility. The surgeon didn't want to do it, but the hospital said, hey, we need to send him out. They put a treatment in place. Once he got to the rehab center, he was okay, but a week after, his incision was not healing and was painful. We noticed his sugars were not controlled due to his non-compliance. Assessment. What we saw the problem was based on the background information like the history, observations, vitals. Well, we know his stump's not healing and he has pain. His sugars are a little bit better, probably because he's having a controlled diet. But the insulin coverage is not sufficient for what he needs. We all know after surgery, especially with infection, blood sugars go up while we heal. We also noticed that the wife's been bringing in sugary foods for the patient, and he's at the vending machines getting unhealthy snacks. We feel that the patient and family do not understand the importance of his sugar control. Finally, recommendation. What is needed? If any orders are given and repeated back. This is the analysis and consideration with options. How do we correct this? Well, we decided to consult a nurse practitioner in the endocrine. She's going to educate the family and patient, give him a new coverage to adequately control his sugars. We also added a psychologist for his behavior modifications. Maybe he's depressed. I would be if I lost my foot. They went to weekly psychologist visits and got him into a support group for amputees that happens daily. Brought in the daughter to support the wife and patient. All this put into play. The patient improves, becomes more compliant with the treatment. And physical therapy and occupational therapy have worked with him. He's gotten stronger and his infection's gone. Sugars are good. And now he can be fit for the prosthetic and start therapy of walking. How did we come to this decision? Well, Interprofessional Education Collaborative, or IPEC, is put in place. This is a way for us to improve patient care by preparing us as professionals with team-based care. It's a way for us to deliver safe, high-quality, accessible patient-centered care that everybody deserves. It takes each profession's specialty and ensure all aspects of care are covered. Well, IPAC has 4 core competencies. And under each core competency, there are sub-competencies that are tweaked just a little bit. The 4 competencies are value and ethics, roles and responsibility, interprofessional communication, teams and teamwork. Under value and ethics, we need to work together to maintain a mutual respect and shared values. Under each core competencies are the sub-competencies. I'm using value and ethics 1. Place the interests of patients and populations at the center of the care and the delivery. We use policies with the goal of promoting health and equity across the lifespan. We also need to use value and ethics 5. Work in cooperation with those who receive care, those who provide care, and those who contribute the support of delivery and prevention for healthcare programs. Finally, VE6, develop a trusting relationship with the patient's families and other team members. These 3 sub-competencies use the dietitian to discuss eating plan, incorporating the psychologist and family to maintain goals of lowering blood sugar and make sure the patient has the best chance of wound healing. We added the support group, which makes a trusting relationship with the facility and improved care upon discharge. Trusting relationship is so important. If they don't trust what you say, they're not going to do what you need. To help avoid these ethical issues, the education should have been started prior to surgery. Reinforce the importance of a healthy diet and wound healing to the family and patient. If the wife had known that this was going to cause a problem and affect his wound healing, she may have chose not to go get him these sugary items. They should have prepared the patient and family on losing a limb and how to manage emotions and feeling for loss. I mean, that's a big deal. You went in with a foot and come out without one. I can't even imagine what that feels like. I know what it feels like to not be able to use your knee for 2 years, and that was very difficult. And if I didn't have a good psychologist, then I probably wouldn't have made it very far. And it's just very important to have a trusting relationship. Under roles and responsibilities, we use the knowledge of one's own role and other professions to accurately assess and address healthcare needs of Mr. Rivera and to promote and advance the health of populations. RR2, we need to recognize our skills and limitations. I don't know a whole lot about endocrine. We brought in the practitioner. Her expertise is in monitoring blood sugars and navigating the correct insulin regimen for the patient. Roles and responsibilities 4. Explain the roles and responsibilities of other healthcare providers and how the team works together to provide care. We added the endocrine nurse practitioner and the psychologist and the amputee support group. All these working together puts a trust and makes him and his family know that he's not alone. We're using unique complementary abilities of all members to optimize the health. We listened to PT and OT with his pain, not completing his therapy. They reported to us. We have a trusting relationship with our other professionals, and it puts on a united front. The next roles and responsibilities. Were there gaps in this case? Yeah. Prior to the submission, he should have been addressed, such as adding some infectious disease, maybe having somebody from the facility come and speak to him. A lot of times we are in fear, not knowing where we are going. Invite the family to visit the rehab center. We needed to watch his elevated sugars prior and educate him on the normal blood sugars and why it's important with wound healing. Also preparing the family for foot loss and feelings that might arise. Needed to be educated on mobility issues. I'm pretty sure none of that's done in this case. The next core competency, interprofessional communication. Communicate with Mr. Rivera, his wife and daughter, and their community. Our team of professionals in all fields give a quick, responsive manner that supports a team approach and promotes and maintains the health, prevention, and treatment of disease. Subcompetency CC4, listen actively, encourage ideas and opinions of other team members. Having a morning meeting and everybody getting together and speaking about each individual patient and what the problems arose overnight. We utilize the social worker and psychologist to talk about how to live after the amputation and support his mental health care needs as they occur. CC6, use respectful language and appropriate when difficult situations, conversations, or conflict. Nobody wants to talk about somebody losing their foot. It's very hard, but it's very important. We communicate in CC8 the importance of teamwork and patient-centered care and population and policies. We encourage the patient and family to speak without judgment, how they really feel in terms of their educational level. You're not going to do any good using big old words that they don't understand. So we all need to get together and talk about what has worked for him. Maybe look through his history, see if he did see maybe a diabetic educator in the past. The final core competency is team and teamwork. We applied this relationship building values and principles of the team to perform effectively. We have different team roles. We need to plan and deliver. Evaluate Mr. Rivera's care that is safe, timely, efficient, effective, and equitable. Subcompetency TT3, engage in health and other professionals in a shared patient-centered population on the problem. We knew he was going to have a problem with eating. His sugars were high, so we got the psychologist and dietitian on board to talk to him and maybe set up a plan that he agrees with. Integrate the knowledge in TT4 to experience in health and other professionals to inform healthcare decisions while respecting the patient and community values. It's important to ask maybe what his eating preferences are. If we're talking about stuff that he doesn't, if he's a meat and potatoes guy, he doesn't want to talk about vegetables. We need to find, and it's okay to have a treat every now and then, but while you're healing, we need to talk about what he's willing to do and work with that. Maybe his religion, he can't eat pork. We need to know that. TT5, apply leadership practices that support collaborative practice and team effectiveness. We need to listen to everybody, nursing assistants especially, direct care nurses for their input. They're the ones that are with the patients most of the time. They're there for the betterment of the patient and the family, and we spend the most time with them on the floor. The nursing assistants are the unsung heroes in the healthcare team. They are excellent, and patients talk to them the most. On Mr. Rivera's team, which we've talked about before, is patient, the wife, and the daughter. The nurse and physician, they're dealing with the general health of the patient, high blood pressure, stump care. Physical therapy and occupational therapy are there for strengthening, making sure he, doesn't lose loss of his other, bad leg, strengthening that, and when he's ready, get him ready to walk with the new prosthetic. The pharmacist is on board for medicine management, maybe with allergies, any kind of, a lot of antibiotics have interactions with blood pressure medicines. If he's on a blood thinner, we need to get certain labs. If he's on antibiotics like vancomycin, we need to have peaks and troughs to make sure that the levels are correct, and it runs through the pharmacist for redosage. The social worker, very important. When there's family dynamics, when people don't get along, we got to know. Insurance issues, and they're so important upon outpatient discharge, about outpatient therapies, any scripts or medical equipment they might need, what's covered by their insurance upon discharge. We have the endocrinologist, nurse practitioner, and dietitian control his diabetes, weight, and a meal plan. The psychologist for mental health issues, depression, anxiety, any of those feelings of loss, how to deal. He may feel like less of a man without his foot, and that's very important. And how the wife and family need to deal with that. The orthotist prosthetist is the doctor that fits the foot, and then they go to therapy. Which teams could have improved the action and interaction of teams? Well, I think the hospital dropped the ball. It happens all the time. They could have had a diabetic educator come and talk to the patient while he was in the hospital prior to make sure that he understood why he needed to keep the sugars low. They could have had psychological therapy, somebody come speak with him. He's losing a vital part of his body, how life will change, and prepare the patient for life after surgery. Even the skilled therapy kind of fell through. we could have gone and visited him in the hospital and gave him an idea what kind of room it was going to be. The wife could have come toward the facility. A lot of that is fear, and say what we had planned for him when he got here. There's a big misstep between hospitals and skilled care facilities, and it needs to change. It's terrible. The unnamed health professionals to improve performance. Well, that surgeon, the one that cut his foot off, a lot of patients look up to surgeons, think that they know everything, and if they don't speak to you, then it doesn't matter. They should be more open to have conversations. The nurses' assistants, they help the patient with activities of daily living like bathing, washing, walking, dressing. They're with them most of the time. They can reinforce the diet and just being there and listening to the patient. Sitting on the bed, rubbing their back, being an empathetic ear. Nursing assistants are wonderful. And the activities department in the skilled facility or rehab facility could keep them busy during downtimes from therapy. I know I was in a skilled facility for antibiotic therapy, and I was depressed. It was not a good time in my life. And I went to bingo, and it was the best time I had. I won a silly little prize, but for that hour, I got out of why I was there, and I joked with other patients that were kind of stuck in a wheelchair like I was. It was wonderful. Mr. Rivera had a large team, and I see these teams more in big cities, Columbus, Chapel Hill. My son had a huge team. The pros, you get more input. If you're just with a doctor and the psychologist, you don't have a wide array, but having the dietitian, psychologist, surgeon, endocrinologist, all that together, we can all talk and give holistic care. He is a complicated patient. And it shows the patient family that we can work as a group and get a trusting relationship with them, because that's what's most important. The cons of large teams. It's hard to coordinate care and make sure everybody's heard. It's hard to get everybody together. A surgeon might have surgery, can't do it on Thursdays. It's very hard. We have Zoom and all that now. COVID kind of bring that to the forefront. So we really don't have an excuse not to set up these programs. This large team, overlapping roles. The dietitian and the endocrinologist kind of do the same thing. And if they're not on board saying the same thing, then the patient's going to be confused and not do anything. It causes reduced motivation. The team decrease in effort due to their size, and they just don't feel their specialty is important. The nursing assistants are number one when they're like, nobody listens to me. I could have told you that last week he was depressed. We need to listen. How do we combat these issues? We need to have education on how to work together. If we don't have a program that gets all of us together for the better of the patients, then we need to make one. We can have in-services. We can have, go to different things, have a luncheon. We need to be clear with everybody's role. If we're clear with everybody's role, we're all in it for the same. We want Mr. Rivera to stop getting an infection, get well, eat well, maintain his function, and go home. We need to address his mental health and his physical health. And this is what we do and why we are in the healthcare field. Thank you very much. This concludes my case study.